for 3 years, and then they go on to be family practice physicians. So that's my job. I've been that for the last 8 years as the faculty for our family medicine residency here at Kaiser Permanente in Santa Rosa. I have 8 years, or now been around for 8 years, but for 9 to 10 years of reviewing applications, reviewing personal statements, interviewing, grading, interviewing, all the things that you would do to be able to get to the next phase. I have a lot of practice in that, many years of practice in that. So I'm one of the reasons why I like doing these talks and these mentoring, to kind of show you all what medicine looks like and what are all the things that entail medicine other than reading about this organ system or that organ system. So there's a lot more that goes to healing in medicine than just the books. So you all are going to have plenty of time to stress about the book. So I'm going to talk about the other things, which is mainly communication. It's about how do you talk to patients in the room. As a little aside as well, I like to introduce myself a little bit more. I'm from California, from actually born and raised in San Jose, and also grew up went to high school in Central Valley. From there, I've gone all around from undergrad at UC Davis to medical school in Cincinnati to graduate school in Philadelphia. I was trained as a rural medicine physician, and I was working in Southern California in the mountains for some time before I decided to come up here to North Bay and start doing the teaching and training of the family medicine residency. So I've had a very long career to get here. I think even in what's used now is a non-traditional student. So once I graduated once I graduated undergrad, I took 5 years in between to go to grad school, post-bac programs, work, eventually getting into medical school. So hopefully that knowing that journey will let you know that it doesn't have to be straight through. And actually, very few people go straight through from high school to undergrad to right into medical school. It's usually either high school to either junior college or to a four-year university. And then usually something happens between undergrad and medical school, anywhere from 1 year to 5 years until you get in. So hopefully that will take a little bit of stress off you all. I think we heard everyone here. So we're going to have the chat, and if you want to type anything in the chat to talk, please feel free to do that. But this is a small enough group that I think if you just either raise your hand or just turn on your mic and interrupt, I think that'll be fine as well. So what I'm going to do here, I'm just going to share now. Let me know if y'all can see that.
Yes, we can see your slides now.
All right, we're good. So what I'm going to be talking about is the 4 habits of communication. And what is the 4 habits of communication? Why do we need to know about how to communicate with people, right? There's a lot that goes into healing that is more than just am I smart enough to know what's wrong with the patient? What we have to do as physicians, we need to be able to take all that complicated, complex information, and how do we communicate it with the person so that they can fully understand what's going on. Has anybody ever been in a visit where you've had a talk with a physician and you were just left with, okay, what did they just say? What does that mean? Has anybody ever had that experience at all?
Beatrice said yes.
Yeah, absolutely. And so one of our goals as physicians is being able to relay that in information that our patient will understand, because no matter how good we are, no matter how smart we are, if our patient doesn't understand what we're saying, then their health is not going to improve, and then thereby we've actually failed. So that's why being able to communicate with patients in a specific way, not a specific way, and using a certain frameworks is going to be the most helpful for you to have better outcomes with your patients. So what we are going to do, so by the end of this lecture, what I want you to know is kind of have an idea of what are the 4 habits. And then thinking of, because it's going to be quite a while before some of you are in with a patient, but thinking about how can you utilize some of these 4 habits in the discussions that you have, especially when you have discussions that are maybe a little bit more higher stress or require a lot of information. So I'm hoping that will be useful for you at the end of this lecture. So what are the 4 habits, right? 4 habits are mainly 4 things. The 2 easy ones, there's the beginning, invest in the beginning, invest in the end. You want to make sure it starts off well and make sure it ends off well. But what about the middle? What happens in there? And that's where we start talking about, 1, eliciting the patient's perspective. What is it that they think is going on? And then the other is very important, is demonstrating empathy. Empathy is extremely important as a physician, especially when these types of situations, when you're talking about healthcare, that can be very stressful. But why? Why do we have to create a framework of how to talk to patients? Well, there's several things. One of the things that is important, as we talk to patients, one of the ideas that we have for medicine and for healing is this quote that I really like, is way before they come to us, the patients themselves are storytellers. They are narrators of suffering. Suffering doesn't have to be anything bad. It could be even a cold. When I have a head cold and I'm congested and I can't breathe, I suffer. That suffering is way different. And plus, as a guy, small things make us suffer. But anyways, it's way different than the suffering I have, but that's kind of the same. What we've done is we are a narrator of suffering. We've traveled to a place that Siddhartha Mukherjee says is a kingdom of ill. In order for us to relieve that, we must begin by unburdening that story. One of the reasons why I love that, it's very important. One of my backgrounds, as well as a Chicano physician, is the Mexican indigenous roots as well. And a lot of those roots that we have shows that we are all connected by story. And it's the story that provides the healing that we need to get better. So when I read this quote, it was great to hear another artist and physician to write the same thing, of how the healing, the purpose of us is to unburden that story. In order for us to unburden that story, we need to know what questions to ask and how to ask. And by doing so in a way that's empathetic, we can now start to unfold that story and see where that story is going to lead for their healing. How does that sound? Has anybody heard that before? Is this news to anybody? Or is it surprising to anybody? I guess I should ask that. Nope, not surprising. Good. All right. So why then do we have these 4 habits, Dr. Martinez? What's the purpose of this talking? Well, one of the things that we know in the American healthcare system, there's a very finite time that we have where we're talking with the patient. During that time, especially as a primary care physician, my job is to manage not just one health system like a heart, not just one health system like a kidney. My job is to understand all of the different organ systems and what happens when they go wrong. In addition to that, knowing all of those systems, how do I make sure all those systems are working well in that 20-minute time frame that American healthcare system gives us? It's a lot of things to do. It's a lot of hard work, which is why it's such hard work to be a physician. But what we know with these ideas of how to communicate with the patient, we know that we can be very efficient and empathetic with this framework of talking. And in doing so, we are able to get through that time efficiently, effectively, and very productively, where the patient could get better. So that's why this framework is very important for talking. The other question always comes up is, do all physicians have this training? And the answer is no. Communication is not always taught in medical schools or in specific ways. So having this in your toolbox before even getting to medical school, of being able to demonstrate how well you can communicate, is going to be a big plus for you all. So I talked about this already. So why? Yes, we're talking better, but why? What is the point of being able to talk well? Well, we do know that these have shown that patients listen to you better when you talk, when you have better communication skills. When they listen better, that means they're healthier. And that's why we want patients to come to us, right? We want them to be healthy. The other thing that happens is patients are a lot happier with their physicians when their physicians can connect with them and talk with them real. That's what patients want to see as well. When the patients are happy, when the patients are healthier, that actually leads to physicians being less stressed because the workload decreases because your patients are getting better and they're getting healthier. That is one of the byproducts of this communication tool to get our patients to better. And who doesn't want stress to be decreased, right? I mean, we're stressed enough as it is. When you all become physicians, you're going to see that the stress level that you may normally live here, but now you live up here. So, of course, we want to be able to decrease that stress. But the other important thing, you can do all of these tools, all decompress, get all the information in without making your office visit 2 times longer. So all of these can be done in the time frame that's given. So let's just dive into the four. And I'm going to try to get this, hopefully not take the full hour, but so that way leave time for you to ask questions to see how relevant this is to you all. But let's start with the first. We'll start with the beginning. When the patient comes in, let's start with the first few minutes that you're going to have with that patient to really make that connection. And that's what's going to be a really strong basis for you all talking in the visit. And of course, I don't know if you can hear my dog in the background, so I apologize. There's probably a delivery guy coming, so he's going to go crazy. And yep, there they are. So, what's happening in the very beginning? That's when several things are happening. We're creating rapport, meaning we're making that connection. You only have a few minutes to make a connection with somebody, which is actually very hard. If you all think about it, how many of you gone to a group of people that you didn't know and try to make a connection with somebody and do so within about 30 seconds to a minute? Is that easy for anybody to do? Not really, right? It's very, yeah. So what we want to do is want to be able to create that rapport right away so that you have that connection. And then when you have that connection, you're able to bring out the why. Why are they in there today? What are their real concerns? And then you can plan the visit to see what is this going to look like given all the concerns that they have. This is going to get to the real reason as to why they're there. This is going to help you navigate the visit as well so that you're going to minimize some of the conflict. And who knows what anchoring bias is? Who can come off microphone and answer what anchoring bias?
I think it's like when you think that it's one of the diagnoses, but it could be that one or like other ones. So you like hold on to that one thing that you think it is.
Exactly. Perfect, perfect, perfect. Yep. If you go in thinking, oh, this is clearly pneumonia, you're going to ask questions just about pneumonia. And you're going to miss all the other questions that's going to help you figure out what it could be. So making sure that you get all of their concerns is going to eliminate that to make sure you're being complete as a physician. The other thing that's highly important is by doing this as well, you're going to eliminate the doorknob question. The doorknob question is once you're done with your visit, you think you had a good time. As you're leaving, the patient says, oh, by the way, you didn't ask, but I'm having chest pain every time I'm walking. Uh-oh, right? The 20-minute visit now turns into a 40-minute visit because now you got to answer the other questions, which if any of you have been patients before and you're waiting in the office and it just keeps getting longer and longer that you're waiting, that's what we want to eliminate, right? And so this, investing in the beginning, is going to be very helpful for you to prevent that from happening. So how do we do that, right? It's a lot of you probably have this already, but it's very easy from the beginning. Coming in and making sure you're shaking hands, or whatever other cultural norms people have to be able to introduce themselves, that's going to be the best way. For my patients as well, when I introduce them, or after I've known them for a while, when we come in, a lot of the time it's about hugs. I have a lot of my Spanish speaking population that is a lot older as well. Now that I've gotten to know them for the last 13 years, the way we greet each other is with hugs. It's no longer handshakes anymore. So whatever is culturally appropriate. The other thing that's very important is when you will go into the room, sometimes they have their family members with them or other people with them. Very important for you to not just introduce yourself or shake hands with a patient, but also look to who else is in the room and see who else is there and introduce. Small things like if you're coming in to see, oh, hi, Mr. Jones, nice to see you today. Very important to ask them how they want to be addressed, right? How would you like for me to address you? What would you like to be called? That gives them people to say, oh, my name is, instead of, I know my uh, name on my chart says Bartholomew Richards, but please call me Bart. So that's going to really allow you to cut right into the chase to make those connections. Physicians are always late because there's so many things that happen in a visit that doesn't go by the book. So sometimes people have to wait a lot. When you are going into the room, and let's say they've been waiting for a while, it's very good to acknowledge their wait. What you don't want to do is say, hey, I'm so sorry I'm late. That always puts people in a negative light, and that puts you in a negative light. What you want to do is set up the stage for positivity. The way to do that is, instead of saying, I'm sorry for being late, it's important to look at the positive. Say, hey, I really appreciate your patience today. Now you have all of my attention. Where would you like to start? And that already kind of sets with the positive tone and the positive light, giving positive affirmation to the patient, is going to set that visit up in a little bit different tone as opposed to being extremely late. As you go in the room as well, so we've already done that. You've gone in, you made a really good connection with the patient. Let's say this is the first time you're seeing somebody or you're talking to somebody. It's good to know. Sometimes it's really good to know that you know them already, right? Having that similarity is a similarity bias that we have, that we love being around people who know us already. So how do you say that to somebody if this is the first time you're meeting them or if you haven't seen them in a while? One of the ways to say, hey, I've taken time to look at your chart and I've reviewed the information from the medical assistant. And that already tells them that, hey, this doctor's already taken some time to get to know me. Without me having to prompt him or anything, this doctor cares. It's those small things like that that really do show that you have making that effort for the connection. So when you get to, well, let me look, see, it's probably better for the next slide. Yeah, so when you get to the asking somebody what's wrong, what's normal teaching in medical schools have open-ended questions. Everybody have open-ended questions. When you go in, ask an open-ended question. Say, what can I do for you today, right? Or something like that, as opposed to, even if they come in and say their arm is hanging off, you don't want to concentrate just on the arm. You're still going to say, I see that your arm is hanging off. Anything else you want to address? That is kind of a very extreme example of open-ended questions, but also being making sure you're giving them time to talk about whatever they need to talk about. However, there's a little asterisk to that. When you go in and a patient has issues and they've already talked to the medical assistant saying, my stomach hurts, and they've talked to when they check in to the receptionist, say, my stomach hurts. And when you come in saying, hey, what can I help you with today? Somebody who is in pain or not feeling well and have to repeat themselves again and again and again, it's kind of hard for them to be like, God, it's really easy for them to be like, Doc, didn't you listen? Didn't you read already? Like, I'm hurt. So this is where I wanted to kind of give the little caveat of open-ended questions work well, but there's ways to do it better. If somebody were to come in with the abdominal pain and be like, hey, Mr. J, I see that you have some abdominal pain. I was able to read through your chart and I got this message from my medical assistant. Normally, I just really like to hear everything from the patient. So tell me more about what's going on today. Boom, right there. What's going on today is a very open-ended question. But you've already been able to address that. I know what's going on. I heard about the abdominal pain. But let's make sure we're hearing everything. So all of these little ways to get this information is a way that you can really show them that you are invested in them, but also being open so that we're not missing anything. We're still removing that anchoring bias that we have. One of the fun things that I like with my resident physicians, especially when you all get to medical school, is when you go in and talk with the patient, and you say, hey, Mr. J, how are you doing today? And then that's when they say, oh, thank you for asking, because my toe hurts, and also yesterday I got a rash, and then you know what, my head's been itching, and then also every time I eat, my stomach hurts and I belch a lot. Oh, and by the way, I sweat. Is sweating normal? And then also, so they're just going through a list. That is fun because The normal inclination is to say, "Oh boy, okay, we got 20 things to talk about. I got 20 minutes. Let's start going through all this list." But in reality, can you get through 20 things in 20 minutes? Not really. You probably can, but you're not going to really pay attention to anything. But so that's not really the best way we want to practice medicine. So this is where the 4 habits kind of help you give that framework to say, "Hey, Mr. J, those sound really important, but you know what? Your finger is actually hanging on by one piece of skin. I think that's kind of important. What do you think we concentrate on that today? And then everything else we will make a follow-up appointment, or we'll make a phone call in a day to see how you're doing." By doing that, you have the opportunity, you have the ability to say, "Let's negotiate. Let's see what's the more important. I think your finger falling off is important." Mr. J may say, I got 9 more. You know what's more important is this rash that's itching under my underarms and it's driving me crazy. I can't sleep. Okay, great. Now you're getting all of their concerns and what they think is important. Allows you to set the visit better. Allows you to say, okay, then we're going to concentrate on this rash. And then if there's time, we'll look at the finger that's falling off, and then we'll make appointments for everything else. So right away, you have the ability to be able to set the visit so that you can get through the most important things in that short amount of time that you have available. So this allows you to work together with the patient so that you both can prioritize the visit, prioritize the needs. That's what's going to eliminate those doorway questions. When everything's done, they say, "Oh, doc, by the way, I'm bleeding every time I eat. I just start throwing up blood," right? That doesn't sound good, and we don't want that to wait till the end. So using these techniques is going to really help to prioritize the visit and get all of their concerns out so that you can get the visit done right. Does that make sense? How does that sound? Yes. Question. Go right ahead.
Yeah, hey, Dr. Martinez. So I just wanted to touch on this a little bit. So in my personal experience, I've actually been shadowing a couple of general surgery residents at Highland Hospital. And in my time over there, it's been pretty evident. So one week we run consults, right? And during this week, you only have a limited time with patients because, traumas can be called in. And it's really evident in how the general surgery residents over there were able to maximize the time, open it up. But then at the end of the day, coming back to whatever the patient's concerns were. So I think it's pretty cool how I can see whatever's being talked over here on the slides in actual real world applications.
Yep, absolutely, and that's a perfect example as well. Especially when that time in the hospital when the rounding is even shortened even more because they need to run from patient to patient to patient because they have probably somebody in the OR waiting under anesthesia that they need to go cut on. So yes, good. I'm glad you're able to see that. Any other questions or observations before we go on? All right. So we've talked about how do we set up the visit. Now, how do we make sure we're getting the patient's views on what's happening? How do we get their idea of what's happening with the symptoms that they have? Because I can guarantee you, when somebody comes in saying, "Hey, my stomach hurts," you're just thinking something minor. Okay, acid reflux. You don't know whether they're thinking, "Oh my God, I got cancer," or "Oh my God, is this going to lead to other issues?" So that's where it's important for us as physicians to be able to get all of that information out from the patient. So this gets to the deeper meaning. We want to get to that deeper meaning of what they think is going on. This is going to explore the hidden agendas, right? There are so many times as a physician where somebody comes in with something that you think is minor, but it's really just a cover. There's really something else deeper that's going on. They just don't want to go around telling people all their business to the receptionist and to the medical assistant and to the nurse. They just want to keep it for the doctor. So this is going to help bring out those that agenda that you otherwise wouldn't have gotten to. So if I'm sitting there thinking, "Hey, you're talking about abdominal pain, a little bit of burning when you drink soda, easy, acid reflux, don't drink soda." But if I were to ask them, "What do you think is going on?" then you could pull out them saying, "Well, you know what? I had a parent that died of stomach cancer, and their symptoms started like this. I'm really worried I have stomach cancer." So that is what is able to bring out what those deeper agendas are. One of the other things that is very interesting are mood disorders. a lot of times mood disorders can present as over worry or over expression of worry of certain symptoms. And those symptoms don't really correlate to anything wrong, but anxiety and depression do come out a lot with that in the room. Anxiety and depression are some of the most common things that we all experience. It's normal because anxiety and depression is just part of our normal human experience. But for some people, it holds on tight and it doesn't let them go for weeks and weeks and weeks. And sometimes that can manifest as, instead of a patient coming in saying, I'm very anxious today. Actually, it would be really nice if people came in and just said, I'm anxious. Sometimes it comes out as, oh, doc, this is hurting, that's hurting, this is going on, that's going on, and sometimes that's how anxiety manifests, because it's a generalized over worry that does not allow patient to reset back to their norm. And that can sometimes come out as we're exploring these, getting their full ideas of what they think is happening. So we want to get, what is their point of view? What do they think is going on? Or what are their worries that they think is going on? When I mentioned in the beginning of the talk, when we're saying when we're meeting with the people, with the patient, introducing yourself to the other people in the room. And that's where it's very helpful to say, yeah, this seems very worrisome, but what about, you, cousin here that's in the room with him? What, is there anything else that I'm missing, or anything else that other people would be worried about? That will also help bring out the full complement of what their concerns are. Because a lot of times, the patient themselves may be downplaying or minimizing. I'm good. But then the person that they brought in is saying, yeah, well, you know what? Every time he starts walking, he passes out. It's happened 5 times this week. So he's saying he's nothing, but I really am worried. So that is a perfect opportunity for us to make sure that we are getting all of the information that we need to be able to figure out where's the best way I'm going to concentrate my care for this patient. The other thing that's important, there's physicians notoriously get a bad rap for speaking too quick or interrupting too much. Very important when this is happening to get what is going on, or what do you think is going on, to allow them to speak. One of the things that I do here is in my job is I run a simulation program where I have patient actors who act out certain things, certain complaints, and my physician, my residents, get to practice it. When they're doing that, I've actually had them where I say, I don't want you to interrupt or say anything at all. Let them get their complaints out. And we time it. And the longest time that it's taken is probably about a minute and a half of that the patient talks. Minute and a half of a visit out of 20 minutes is not that much time at all. As a physician, we're thinking, oh my God, it's been longer than 10 seconds. My mind's it's going forever. That's by understanding that, really doesn't take that much time. It has allowed my residents to be able to relax a bit and just allow the patient to talk, knowing that it doesn't take that much out of the visit. So that's what I'm hoping to get anything from you all, is that a minute and a half in a visit may feel like 10 minutes, but it's in fact just a minute and a half. So it's very important to allow that patient to just be able to express all of their concerns about what they feel is going on today. And finally, too, one of the things I really want to really good to ask people is, it must be really hard that you can't breathe. How is this affecting your everyday life? How is it affecting school? How is it affecting work? Then you start to get out, well, you know what, doc, I had to call out 3 times this week because I can't even walk from my door to my car. I just get so short of breath. Being like, those are like your warning signs. Like that's the information that I need to be able to prioritize how serious is this person's complaints. So I'm going to pause there because I always want to see how was that landing. Especially, I don't know how many, any of you have been patients yet, but if you've had that experience or have the opposite experience where the physician hasn't listened, and seeing how these types of behaviors can allow them to really get to what it is you as a patient would want. Any questions before we move on to the next one? Nope. All right. So we've talked about investing in the beginning. We've talked about eliciting the patient's perspective, getting everything that they need. Now we're going to talk about empathy. What is empathy? Anybody know what empathy is? If you don't want to answer, that's okay. So empathy, it's recognizing, being able to acknowledge the emotional impact on a patient. That is different than sympathy, meaning you know exactly what they're feeling. Empathy, because you can't feel everything that a patient feels, but it's being open to how it is affecting somebody emotionally. This, surprisingly, as a physician talking one-on-one with a patient, or as a learner, a medical student going into resident, is the most challenging. Because the biggest worry is that, is this going to create a time sink that is going to I'm just going to get completely deluged by emotion, and it's just going to overtake this visit. Or like, I asked them something personal. Now we're just going to go deeper and deeper. But that's furthest from the truth. If there's plenty and plenty of studies that have shown that patients love that piece of connection with the physician. It's that empathy. It may be very hard at every single visit for you to be your most empathetic self and connect so much, but there are small things that you can do that will show how empathetic you are. And that empathy could be something verbally. For example, we are on video visit. Let's say somebody was asking me, was saying something serious. If your friend was on there serious, if they were starting to get very tearful and you just kind of scooted back and then just put your feet up, would that seem very empathetic? Most likely not. But if you did the opposite, and let's say somebody was on there crying and you just stopped and you came in really close like this and get closer, or your face really shows that you're concerned, you start to furrow your brow, that's empathy. That's ways to convey to somebody that I'm hearing you, I'm seeing you. And it's those small things that are going to be very important. So what I'm doing now, I'm going to show an empathy video. All right? Just so we can kind of get the idea. And let me know if you can see it. Make sure it goes past the ad. Okay. Can you all see that right now?
Not yet.
No.
Okay. Let me reshare this. There we go. I'm going to share. Got that. Sound is all the way up. Okay. How about now?
Yes, looks great.
Can you hear it too?
Sound is on. Thank you.
Okay. Let me turn that off. Who has seen that before? That video? Anyone? Nope. All right. How are y'all feeling after that video? Very empathetic? That is one of the things that you as future physicians, what you'd have to be dealing with the patients you see each day. You're seeing about anywhere from 18 to up to 25, sometimes more patients in a day. Each of them coming with a certain thing that has that is affecting how they're viewing that day. And so those are the things. That's the empathy that you want to be able to tap into when you see your patient. Because when you do that, well, let me get on to the next slide here. Because when you do that, hold on. When you do that, having that connection, that is how you're able to make a much thorough diagnosis of why the patient's coming in. Having that connection means your patient is more likely going to listen to you and come up with better outcomes. When that happens, you create more trust with your patient. So this empathy that we worry about, is it going to take too much time? Well, you know what? This is what's important for us as physicians and healers, to make that connection. So it seems, part of that seems hard, like I said, where you're going to be doing, I got to do this deep, this many times with each, how many patients, but it could be something as simple as if you're typing on the keyboard and someone says something serious that they really need to connect with, you take your fingers off the keyboard, you turn your chair and just look at them right in the face. Or if somebody is doing something, they're tearful, reaching over and putting your hand on their arm, or grabbing the box of napkins and giving them napkins. Those are the small things that you can do to make that connection. So it doesn't have to be much, but just having that connection where the patient knows that you are seeing them and hearing them and feeling them is going to make great strides when you're with them in that visit. Questions about that? What's coming up for y'all about that, if anything? Nope. Oh, yep, we got a question.
Yeah, so my question was, how do physicians manage to exhibit like the same amount of empathy, the same amount of understanding, the same amount of patience on a day-to-day basis?
There's a very good, important word that you had in there, same. The truth is, you can't give the same amount to each patient every time, right? Because just like patient has a different concern that comes in, or a different set of symptoms, you tailor it based on the symptoms. And so you kind of tailor it based on what they're coming in with, and you tailor it based on how you're feeling. You're not a never-ending source of energy for other people. You're eventually going to run out of energy. So you need to be able to handle it that way as well. And that comes from learning. That just comes from experience. So I hope that answers your question. All right. So we're making it to the end. We talked about, we invested in the beginning. We made sure we got all the patient's concerns out. We demonstrated empathy. We're very empathetic. Now we're at the very end. The very end is important because this is where they're going to learn about how do you wrap it all up. How do you take everything that you learned, you're able to give them the diagnosis and make sure that they go home understanding what you're talking about. So what we're doing, we're delivering the information. We're educating the patients. It's very important when you're doing this that you are involving the patient. That is going to be the most important, one of the most important tools to do that, because that working together is what is going to get the most bang for your buck. One of the important things to note when you are wrapping things up with a patient is to make sure you're tying it into the context of how what they're really concerned about. Like I mentioned in the beginning, the patient was like, I got stomach pain, and now, you know, my father died of stomach cancer. I'm worried I have stomach cancer. This will give you a way to say, you know, talk about it in the terms, you know, you were worried about this in the beginning, but you know you don't have any rapid weight loss. You're eating well. You're actually gaining weight. All of those are signs that you are arguing against your stomach cancer. So what if we concentrate more on this, which is the most likely diagnosis, and then we'll treat and then we'll follow up in a month if you're not better. That is a way to be able to tie it back into what to their original concern. The other thing that's going to be very simple, or not very simple, the other thing that's going to be very important is to keep the explanation simple. Again, and you all are intelligent. When you become physicians, you're going to have so much medical knowledge in your brain that when you come out saying, you know, Mr. J, what it is, it's GERD, and you have a PPI that's going to be very helpful, so be sure to take this BID. What the heck does that mean? To a patient, they're like, am I dying? I don't know. So it's very important to put it in terms that they're going to know. Mr. J, you came in with some burning of your stomach, which we would call acid reflux or dyspepsia. So dyspepsia is, you know, discomfort of the stomach caused by acid. What you're going to do is you're going to take this medication, which is going to decrease your acid, which is going to help you feel better in a few weeks. And then you go into why diet is important, why you got to eliminate certain foods or take certain foods. So making the explanation that simple is going to be very important for your patient understanding. And then, of course, it's very important to say, like, you know, if you're not better in a couple weeks, or this is what it's going to look like in the next month. You know, if you sprain, you know, you came in with a sprained ankle, well, we have a splint that you're going to use for a couple weeks, and you're going to gradually increase walking. You're going to start these exercises. So by about 6 weeks, you're going to be feeling a lot better. Gives them a long time frame to know what to look for of how they're going to get better. One of the other things that is important as well is to say, well, hey, you know, Tony, you came in, you got this sprained ankle, and we talked about your treatment plan. How are you going to explain this to your family? How are you going to explain it to your partner, or how are you going to explain it to your kids if they come up and ask you what's going on? Allows them to repeat what's saying to see what they understand and what they don't understand. And what they don't understand, you can fill in those gaps. So lots of different tools that you want to be able to use to show that what you're saying is landing and can be repeated as well. So one of the other things is similar to, like I said, they're using their terms of how they presented in the beginning, because you want to be able to involve the patient. But now here's the other end of it, where you need to involve the patient of the treatment style, of what are the different options to treat the actual patient. This is where you're going to have to come into what kind of insurance do they have? What can they pay? Where can they go? Can they even get to the appointments? Can they even get to the pharmacy? All of these is where this comes up now, where you need to be very mindful of this part. Because sometimes you may get to a point where you're like, you know, I think the treatment plan A is, you know, we're going to do X, Y, and Z. And they're like, no, I'm sorry, I can't do that. Okay. Well, the second plan, we're going to do A, B, C. No, that's not going to work either. Well, you know, because of this issue, maybe we do it this way. And they're like, that's not going to work either, doc. Which does happen. So making sure that we are looking at, well, then what is going to work, right? Because obviously there's some barrier that's not allowing this patient to get involved with the treatment. So that's where it comes very important for you to start looking for those barriers. Mr. J, what do you think is going to be helpful for you to overcome this problem to get you to feel better? And that's going to allow them to be involved with the care, to say, this is going to work, that's going to work, and that's going to allow you to continue to negotiate that treatment. So any questions about that? How is that part landing? And I know I'm giving you a lot as well. I don't know how many of you have actually done the patient visits, but I'm sure you all have seen it, and so hopefully this is working for you. But the other thing that we have to do is, us as physicians, we have to be very, because we have the knowledge of interactions and what works and what doesn't and which medications can be dangerous, this is also where it's very important to set limits. This is where we say, you know, I understand you think that, you know, I'm sorry that your ankle's hurting. You know, I really don't think that giving you fentanyl is the right choice right now for what you asked. That's going to be very dangerous. So respectfully, I think it's better to do ibuprofen. That is a very egregious example. Nobody comes in asking for fentanyl. But Just trying to make a point. That sometimes you need to be the one to set the limits to say, no, that's not the right care. That's not the right treatment. And you, as when you become physicians, are going to have to be that one to be able to set those limits respectfully with the patient, reset those limits in the terms that they use to present their symptoms with that patient. Okay. And sometimes it's useful to say, you know what? I wish I could take all that pain away in one day, but unfortunately, this is what happens when you break an arm, right? So the I wish statements work very well. I wish I can give you never-ending opioids, but that wouldn't be the safest, and you wouldn't poop for a week. So that's not something you would want to feel either. So let's go with this treatment plan. So once everything goes, of course, I don't have to tell you, well, it's important to make sure that you end with really good um, pleasantries, really good statements. But even if the visit didn't go the best, even if the patient came in upset, you did everything correct, and the patient's still even upset because they're in pain, because they're sick, because they're scared. Still very important to be very professional, formal, and with pleasantries. I really wish you do get better. I hope you have a great day. I really wish, medicine. I really wish the medical standard was to do that, but because of dangers, that isn't the right way. So I really hope that you're going to get better with the treatment plan that we have. That is supported by all the research in the world. Things similar to that. Now that you've invested in the beginning, you've been very empathetic, you've gotten all their concerns, you've wrapped it up in ways that they would understand, that is going to now eliminate those, oh, by the way, doc, I have this new symptom. And hopefully, if there's anything else that you say, is there anything else I need to help you with? That's when they're going to say, oh, no, doc, you've already said we're going to have a follow-up telephone visit in 2 days for this. Or no, I know that if I'm not better in a few weeks, I'm going to come see you. That is going to make your visit the most productive for you and the patient. So the 4 habits, who can say the 4 habits? What are the 4? Who wants a chance? What's the first one? And I can't see the chat either, so if anybody's typing, sorry. So the first habit, invest in the beginning. Second habit, anybody remember that? Go ahead and come off microphone and talk.
The second habit would be to just see what their concerns are and leave it to them, to open whatever concerns they have. And then the third would be to be empathetic and to be understanding of the situation. And then the fourth one would be ending off on a good note and similar to the beginning.
Invest, exactly. Invest in the end. So invest in the beginning, like you said, get their concerns or elicit their perspective, be empathetic, and then we're going to wrap up by investing in the end. All of that can be done in a 20-minute visit. All of that can be done very efficiently. All of that can be done very empathetically. And all of that is going to lead a very successful visit for you and your patient. It's going to create a lot of trust. It's going to want them to want to come back. It's going to allow them to really listen to you when you are talking about how to care for their health concerns. All of that is going to get their health better and better and better. And as your patients get better and better and better, you are going to be feeling happier and happier and happier having healthier patients. So I'm going to pause there because we're coming up on the end. Any questions, any concerns, anything else we didn't cover? Well, let me ask this as well. Do you think this is something that you could put into practice in your next conversation, wherever it's going to be next week? Good. I'm getting some thumbs up. I'm getting some checks, some yeses. Good. Good. All right. Well, Melissa, we are right at time. So what we're going to do is I'm going to put a QR code in the chat. If you can just do the evaluation for us. Let me stop that. And in the chat is the code. If you can go ahead and scan that with the phone or click on the link, we would greatly appreciate it.
Before we wrap up, I noticed that I think we have a medical student joining us this evening. Is that correct?
Yeah, I'm a med student.
Wonderful.
Or
Can you
Beatrice.
please share what?
Yeah.
Oh, I'm sorry. Go ahead.
No, sorry, I didn't mean to interrupt you. You can go
Can you
ahead.
please share the year that you're in and the
Oh,
school
yeah.
that you attend?
Yeah, I go to UC Davis and I'm a third year. I'm gonna be starting my third year in April. Yeah. Because I ended up taking more time for my step one exam, but yeah. So I'll be starting rotations in April.
All right. Perfect. Perfect time for you to start using the 4 habits of communication. And one of the things I always tell my residents as well, don't expect to use all 4 habits entirely on the very first visit. Pick one thing. Pick one thing that you think is the hardest for you and start with that one. Or if your brain thinks opposite and thinks, let me just try one of the easiest ones that I know I can do and let's see how it works. So Beatriz, can I put you on the spot and ask
Yeah, go
which
for
one
it. I
is
can turn
calling
on my
out?
camera too. Uh-huh. Sorry, let me turn on my camera. I think, yeah. Sorry, go ahead.
No, just ask which is there one that you think is jumping out saying this is one thing I want to try at the next with my patient visit.
I think probably I think just like the first one, like building the rapport early. I think, and I think, sorry, something that I also struggle with is like bringing in the patient like into like their like what they think. So I think like finding a way to phrase it to be like, oh, like what do you like? I don't know how to phrase it, but like what do you think it might be or something like that.
Yeah,
Yeah.
very very good. If there's time, I want to answer that as well.
Hmm.
Um, I have a lot of Spanish speaking patients, and with my um, what I notice more culturally is that if I ask them any questions, it's more you're the doctor, you tell me. You're the doctor, you tell me. It's just how it um, just how our culture is sometimes. So the way I present it with a lot of my patients is I say, we've got got all of your symptoms. I have a really good idea about what's going on. So before I talk about treatment plans and next steps, I just want to make sure, what do you think is going on? Or I start to bring up what were you hoping to get from the visit today? Those are the type of questions that I would use to kind of pull out from them what they think is going on.
Okay, that's
How does
pretty
that sound?
helpful. Yeah, that sounds great. Yeah,
Good,
thank you.
good, good. Any other questions, concerns? Thank you for filling out the evaluations as well. Anything else, Melissa, that we need to cover?
No, that was wonderful. Thank you so much for Dr. Martinez, and thank you everyone for joining this evening. Yes, please feel free to complete the evaluations. That just lets us know if you're interested in additional topics. We'd be happy to incorporate those in the future. And just be on the lookout for additional workshops, and we'll promote them on Connect at KPNC. So I hope you have a great evening and happy holidays to all of you.
Yes. Hope you all have a vacation and enjoy time off.
Sounds good. Thank you.